Today's presenter is Dr. David Schonfeld. He is a developmental behavioral pediatrician and the director of the National Center for School Crisis and Bereavement, professor of the practice in the School of Social Work and Pediatrics at the University of Southern California and Children's Hospital, Los Angeles. Dr. Schonfeld is a member of the American Academy of Pediatrics Disaster Preparedness Advisory Council and the Sandy Hook Commission in Connecticut, and he served as a commissioner for the National Commission on Children and Disasters. Dr. Schonfeld has provided consultation and training on school crisis and pediatric bereavement in the aftermath of a number of school crisis events and disasters within the United States and abroad, including school and community shootings in Newtown, Connecticut, Aurora, Colorado, and Chardon, Ohio, floodings from Hurricane Sandy in New York and New Jersey, Katrina in New Orleans, and Ike in Galveston, tornadoes in Joplin, Missouri, and Alabama, and the 2008 earthquake in Sichuan, China. Now, without further delay, it is my pleasure to turn the webinar over to Dr. David Schonfeld.
Hi. I'm going to be talking about basic strategies to establish a therapeutic relationship in a primary care setting. And the goal of my presentation is really not to give you information about what you should say in an interview, but instead to discuss how you might approach the interview process. And that might be whether you're doing a diagnostic interview or a therapeutic interview. The goal is really to obtain accurate information efficiently, but I'm going to try and emphasize how do you establish a therapeutic alliance with the patient and the family in that context. And I'm going to go over some very general and basic principles and approaches, but I'm not going to restrict my comments solely to obtaining a mental status exam or history related to the diagnosis of a mental illness, because many of the same approaches are useful if you're obtaining a history of a physical illness, or if you're just trying to deliver advice for the initial management of a behavioral concern, for example. So the reality is that primary care, I should have said that I have no financial relationships to disclose, and I'm not going to be talking about any unapproved or investigative commercial product or device. Pediatricians in the United States are the de facto mental health providers for children. Children are actually most likely to receive treatment from primary care physicians for mental health disorders, and most of the psychotropic drugs are prescribed by primary care physicians and not behavioral health specialists. And psychosocial problems turn out to be the most common chronic condition for pediatric visits. Yet it appears to me that pediatricians are often hesitant to ask about behavioral health problems, since they feel they don't have the skills, resources, or the time to solve them, and often aren't reimbursed for it. And I would question why that would limit it so much, because we diagnose medical conditions for which we don't have effective medical treatments. And we know that it's helpful for families to understand what's going on and to have their concerns acknowledged, even if the problems can't be solved, at least immediately. So I would encourage people to use some of these techniques so that you form a therapeutic relationship, and people will feel more comfortable at least telling you about some of their concerns, even if you don't have, the resources, the time, or the ability to fully address all of them. Just, acknowledging they're present and starting the conversation can be quite useful to families. So one of the first things that you need to do is to create an environment where it feels safe for both children and youth, as well as the parents, to share their concerns. Now, I know a lot of times people say, well, make sure you tell them it's confidential. And obviously you should do that, but you also need to create an environment of trust and respect where it feels like that confidentiality will be, genuine and will occur. So one of the things that I do, and again, these are some very basic strategies that you may or may not wish to use yourself, but whenever possible, I try and greet the child first. So when I was working in a primary care clinic for many years, it wasn't it was a primary care clinic in a teaching facility, and they didn't have a lot of nursing support and other front office staff. So I often would go out and get the patient from the waiting room, in a large waiting room. So what I would do is I would call the name of the patient. I know we don't do that because of HIPAA now, but when I would first meet the family, I would talk to the child first and say hello. Part of that was, that's the only name that I knew, was the child's name if it was the first time I had met them. But it's also, I wanted to establish from the very beginning that the child is my patient. And when I say child, it might be a youth. Now, obviously, if it's a newborn or it's a 6-month-old, I wouldn't greet an infant first. It was 6 months old. But whenever the child could acknowledge that I was there and would be aware of the fact that I was greeting them first, then I would do that. If the child is old enough and it's appropriate to the situation, it isn't always, I offer to meet alone with the child. Now, in most situations when it's a new patient, the child will want a parent or parents or whoever caregiver is with them to accompany them into the visit to begin with. But I want it to be clear from the very beginning that that's a choice that the child makes. And that way, when later I suggest meeting alone with the child, it isn't a surprise. I've already said from the beginning, you know, I can meet with you now alone if you prefer. I also then have the child introduce who they've brought to the visit with me and invite that person to come in if that's what they wish. Now, one of the questions that often comes up is whether you want to conduct your initial interview alone or whether you want the child to be present while you're also talking to the parents. And sometimes, you know, I hear people say, well, it's better to interview the parents without the child there because the parents may say something that's embarrassing or uncomfortable. Well, the issue for me is I think it's better to obtain, in most situations, the history from the parents in the presence of the child because then you can actually hear what's said by the parents. Now, if the parents say something that is completely insensitive and disrespectful to the child, I will tell you that it probably pales in comparison to what they're saying when you're not present in the room, such as at home. So, you know, I've had some individuals say to me things like, well, you don't want the parents to talk about, for example, the child wetting his bed in front of the child. It might embarrass him. Well, if they don't handle it with sensitivity in your office, then chances are at 2 in the morning when they're woken up to change the sheets, they're not going to be talking with a very sensitive tone at that point. So I think it's useful for you to hear how they approach it. Now, obviously, there will be some exceptions to this. So if the parents are coming in to talk about some marital conflict that they're having, which may lead to separation, for example, but they've not talked with the child yet about this, then that wouldn't be something you would talk about with the child present. And, of course, there may be some situations where you talk just with the child. So the next thing is establishing ground rules for confidentiality. A lot of this is you want to make sure that you include some discussion or explanation of what the limits are of that confidentiality, not so much because that's going to happen very often that you're going to exceed those limits, but actually by expressing the limits, you can also tell them what is not something that would be grounds for you to break confidentiality. It's best to do this as early on in the interaction because if you wait until much later, say at a following visit or at the very end, sometimes that makes it suspicious and the parents will wonder, why now are you mentioning this? So if you, from the beginning, say, you know, you explain the ground rules for your confidentiality and say that you will be talking with the child alone at times and you will respect that confidentiality except for those when it exceeds that limit, that's, I think, much better than to wait till the child, you know, a teenage girl comes in with vomiting and nausea and weight gain, and then you say, oh, by the way, I want to meet with her alone. Then it becomes a little suspicious. I also try and make sure, though, that even though I want the child to feel comfortable talking with me alone and understand that their comments can and will be held in confidence, I do encourage parent-child communication as much as possible. So when I do counseling, and so when I meet alone with children and the parents are in the waiting room, let's say, I will then ask the child to go invite their parent or parents or guardians to come back into the office to talk with us so that we can summarize what we discussed or we can continue a conversation about one of the issues that has come up. If the child, and then what I will do is talk with the child about what it is that they will say, what they feel comfortable discussing, and what they would like me to share during that communication. And then I have the child get the parent who, because I think it's important that they invite them back in for that discussion, and then we go over what was discussed. I also, though, try and limit private conversation with parents. So I think when parents come up to me and they say, well, I just want to talk with you, but don't tell my kid, the problem with that is it's very hard then to manage most of the issues that come up in that way, because you can't tell the child what information you have or how you've obtained that. Now, there will be some situations where that might need to occur, but again, that should be quite limited in frequency. But in general, when parents say, well, I just wanted to ask you about this, I usually say, well, why don't you do that when your child's here, because it actually involves your child, and that way we can all talk about it together. There are, of course, situations where parents call me up for an initial intake visit, and they discuss at length their concerns or issues about why they're going to come for the first visit, but then we summarize that information when the child is present so the child understands what's been said. If children have conversations, if parents, have conversations without involving the child with you, then it may make the child reluctant to share that information or to discuss it with you. I was seeing one adolescent who came for a different reason, but during that conversation, the dad brought up an issue with me later on and said that there was an issue that he had concerns of regarding his son. I think it was that he was an adolescent male, and they were quite religious, and he had found that his son was watching pornography on the internet, and wanted to bring that to my attention and called me in between visits. And then when the child found out that I had discussed it with him, he was very upset and embarrassed by that. He also shared with me some emails that his son had sent to him, which illustrated some of the arguing that he didn't do at all during the visit. And at that point, his son met with me and said that that was private communication with his father, that he was offended that it had been shared. And his dad said, but these are the things you talk about with the doctor in counseling. And he said, that doesn't matter. The information that I sent to you, my communication was private, and you shared that without my permission, and I don't know that I'll feel comfortable talking with him anymore. So again, I think whenever possible, you want to limit your private and side conversation with parents. Overall, the primary principle of all of this is you're maintaining your focus on the child. Now, when you maintain the focus on the child, it's maintaining the focus on the child's needs. It doesn't mean that you're taking sides and just advocating for the child. So let me give you an example. I saw one boy who was he was an adolescent. He had reached the age where he could get a learner's permit. He wanted to drive, but his father was concerned because he had ADHD and was not taking medication. He didn't wish to take his stimulant medication. And so his father had asked if that would increase his chances of accidents. I told him that it would. I shared that information, and he brought his son in for the first visit to discuss it. During that visit, the son looked at me and said, so I heard that you said I'm not allowed to drive. I said, no, I didn't say you weren't allowed to drive. I answered your father's question about the safety of driving with ADHD unmedicated, and I just gave him that information. And he said, well, what was that information? So I shared with him the statistics, and he looked at me and said, I would be concerned too. I understand now why my dad made that decision. And he said, but could you tell my dad how important it is for me to drive? And at that point I said, well, your dad's right here, so maybe you could tell him that. That actually seems to be something you want to communicate. So then his dad said, well, if you don't take your medication and you get in an accident, then, you know, that I can't allow that to happen. And so his son said, well, you know, I'm willing to take that risk. So then his dad said, well, yeah, but it raises our insurance if you get in an accident. And at that point his son started to say, well, you know, you can pay the insurance. And I just kind of interrupted, and I said to the dad, are you really worried about the impact on your insurance premium, or are you more concerned about the fact that John might actually be hurt seriously? And he said, well, of course, it's that it would be that he'd be hurt. And I said, well, then let's talk about that. And so whenever the focus got shifted to, you know, the damage to the car, the cost to the father, that then just led to arguments. But when his father was able to focus back on the fact that he was concerned about the safety of his son and his well-being, then his son would actually listen to him. So what I do in the conversations is I just move the focus back onto the needs of the child, because that's why the kid is there, that's why the parent and guardian is there, and that's why I am there. So I just want to make sure, so that's kind of, for me, an overarching principle. So then as you're communicating, you've created some of the environment where people can talk, but then you want to make sure that you use open-ended questions. There is a tendency I see for a lot of healthcare providers to use open-ended conversations with children, particularly younger children, for casual conversation. So they'll ask, what are your hobbies? What are your interests? What did you do on the weekend? Who's your best friend? But they tend not to ask the same open-ended questions, such as what questions or concerns do you have on this visit that you'd like me to address? Or do you have any questions or concerns about your health? They've actually done research and have found that children often come to a healthcare visit, a child checkup, for example, with questions or concerns and leave without them answered because no one has actually asked them about it. The reality is even young children can contribute information about their health status if they're asked about it. So I was made aware of this when I took my younger daughter to a pediatric checkup, and I think she was somewhere between 3 and 4 years old at the time. And she had had a number of ear infections, not a huge number, but a significant number of them. And so when the pediatrician came to do that part of the exam, he just asked her, how are your ears? Have they been bothering you recently? And she said, yes, my right ear is infected. So at that point, he looked in the left ear first, and it was normal, and then he looked in the right ear, and it was hemorrhagic. And so he asked me to come and take a look at it, and it was really quite remarkable, just covered in blood and looked horrible. And at that point, I just looked at my daughter, and I said, you didn't tell me that your ear was bothering you. And she just looked at me and said, well, you didn't ask. I said, well, dear, you can tell me if your ear bothers you. I certainly would do something about it. And she said, don't worry, Dad. It started to hurt this morning. I knew we were coming to the doctor. He looks at my ears, so I told him. I know I could ask you. I was just more embarrassed because I was faculty in the section of general pediatrics, and I knew the attending would be telling people that my daughter doesn't even tell me when she has an ear infection. But the reality is kids know who they should tell, even at a pretty young age, and they will if they're asked. But we have to invite those questions. Now, that's especially the case for mental health concerns, particularly when it involves what we call internalizing states or their feelings, because only they really know how they feel, and so we have to ask them questions about that. You also want to, when you're asking these questions, not just make sure that they're open-ended, but you also want to ask necessary questions in a way that children can understand. So let me start with the first part. You want to speak in a way that children can understand what you're saying, which means that you want to avoid jargon and confusing language that would be difficult for children to comprehend. So here Calvin explains, he says, I used to hate writing assignments, but now I enjoy them. I realize that the purpose of writing is to inflate weak ideas, obscure poor reasoning, and inhibit clarity. He says, with a little practice, writing can be an intimidating and impenetrable fog. And he asks Hobbes, want to see my book report? The Dynamics of Interbeing and Monological Imperatives in Dick and Jane, a study in psychic translational gender modes. And Calvin says, academia, here I come. The reality is that physicians are trained in academic settings. And so we're actually trained to use a lot of jargon. And what happens is it's impressive to people, but it actually makes it hard for them to understand. So you want to make sure that you choose language that's simpler for children to comprehend. And I will tell you that that will make it also more likely that the parents will know what you're talking about. You then want to make sure that you're asking necessary questions. And you don't want to be concerned that asking a question is going to give the child some new idea or prompt them to action that they wouldn't have considered. So asking if they're sexually active doesn't prompt them to begin having sex. Children have many other prompts for that and many other exposures to information about sexuality. Asking if they're depressed or suicidal also doesn't prompt them to kill themselves. It just prompts them to tell you about it if it's relevant and if they feel comfortable doing so. Now, you may want to explain why you're asking a question that may be seen as intrusive or irrelevant. So, for example, when I'm evaluating kids for attention deficit hyperactivity disorder, part of what I will do in the evaluation is I will say, well, want to ask you a question now that I ask all children who I'm seeing who have problems with increased movement and trouble focusing. It turns out that children who have been, and I explain to them that children that have been sexually abused or physically abused may actually feel uncomfortable and have trouble focusing and may appear jittery. So I explain that as a result of that, I ask all children if they've ever been physically or sexually assaulted, if that's part of when I'm evaluating them for attention deficit hyperactivity disorder. If I just ask them about whether they've been sexually abused in that context without prefacing it with an explanation, it might seem to be an odd question. So if I do preface it beforehand to say that I do that at all times and why, then most kids will just say, oh, no, that's not me, or I haven't had that problem. Now, another way to ask questions that may be a little less off-putting is to ask questions sometimes about peers. So you might say that you heard there was a student who died by killing himself in the school, and that you wondered if they had heard about it, and then what are some of their friends and colleagues saying about it? Because it may be a little easier for them to tell first about what they're hearing from other people as opposed to answering direct questions about how they are thinking about it or reacting. And then sometimes what will happen is the child will continue talking in the third person. And I've had some situations where they do that for quite a while, and then all of a sudden they're saying, well, there's this guy and he had a nightmare last night, and in the dream, and it's very clear they're talking about themselves. You can continue in the third person pretty much for as long as they wish. There may be some situations where you want to go and talk directly or ask directly the child how they're doing. So you could say, well, you're telling me that some kids are very scared and worried and upset about what's happened because they really miss the kid or are worried about their own well-being, whereas other kids don't seem concerned and are not fazed by it. Where would you say you are in that continuum? So you might start in the third person and then move it more to asking the child about their own experience. And sometimes it's just helpful to mention that many kids are feeling or acting in a particular way just to normalize some of the reactions. So you could say, I heard there was a student at the school who had killed himself, and I heard that a lot of the kids are having some trouble with that and are feeling very sad and miss him and also worry about the safety of themselves and others. How are you feeling about that? So sometimes you can ask the kid about peers, but you can also share information that you've gathered in a general sense from the community. Obviously, you don't want to share very specific information that you've heard from another patient that might compromise the confidentiality, but you certainly can share very general impressions of what's happening in the community. Another approach is to use what we call projective techniques, and those are things such as picture drawing, art, or play. I think art and play may be difficult to do in an office setting, but certainly you can do some picture drawing. So you may ask them, for example, to draw a picture of the family doing something, or just draw a picture of the family. I would tell you to be cautious not to overinterpret the drawings or to be too concrete in your interpretation. I mean, the classic example is that you ask the kid to draw a picture of a parent and they get they make a picture and it's all in these thick black lines that look very, severe, and you make some conclusion about their relationship with the parent. And then you ask the child, well, why was it drawn this way? And they said, well, I only had a black crayon and it was broken. So the issue is you don't want to be too concrete in how you interpret it, and realize that when you ask children to draw pictures, for example, about something that's upsetting, like a crisis that they've been in or some natural disaster that's occurred, when you ask them to draw about an event that was upsetting, the pictures might actually look upsetting, and that's not to be interpreted as that the child is somehow reacting inappropriately. I think mainly what I do is when kids have done these pictures is I ask them to explain what they've drawn or to tell me the story about it. and then to explain why they've drawn it in that way. And I think that's what you'll probably learn more from rather than just looking at the picture itself. The next thing here is to just make sure that when you're taking a history, to do it in a non-judgmental manner. I think it allows you to obtain much more information. So, for example, when I would ask parents about physical punishment, I would ask them, I would say, when your child doesn't do something that's important that you've asked them to do, how do you usually approach that? And then I would ask them, well, what do you do when they don't do what you want? What strategy or approach do you use? And, often parents will say, I take something away, or they might say that I, give them some penalty. I don't let them watch television, or I make them do something else. And then I go, well, when that doesn't work, what do you do then? And then eventually they might say that they use physical punishment. Or they may not, and I might say, well, how often do you find that you have to use physical punishment? And they'll go, often they'll say, well, sometimes I have to do that. And I'll say, well, how often would you say that you actually strike your child? Would you say that you strike your child every hour, every other hour, twice a day, 3 times a day? Just the same way I would ask about abdominal pain. And then, they'll say, okay, well, maybe I hit him, but it's not every hour, it's maybe every other hour. And I say, okay, well, how often do you find that you use anything to hit them? Since you say you hit them about every other hour, would you say that you use an object to do that every time that you hit them? And then in the same way, I'll just ask the questions and ask if they, what do they strike them with? Where do they strike them? Now, that does not mean that I don't have an opinion. It's just that I elicit the information without voicing the medical opinion first. So, I might then say, oh, well, it sounds like you find that you have to spank or to strike your child several times a day, and that at least once or twice a day you're actually using a belt. Let's talk a little bit about physical punishment and what you might be able to do so that you restrict the use of physical punishment. And I, will say to them, I don't think it's appropriate for them to use an object when they're striking their child. So I don't mean to convey that you don't have an opinion or voice that opinion. I think you should voice the opinion when it's standard medical practice. We can talk about what do you do when you have a personal opinion. But if it's about a medical practice or a standard of care that's well accepted within the community, you should, of course, convey that. But I think as you're first collecting your information, you want to do it in as non-judgmental a way as possible. Because if instead you said, you don't hit your child, do you? You'd never hit him with a belt, would you? Then it's judgmental, and you're unlikely to get accurate history for that. You also want to remain sensitive to underlying issues and agendas. And so often the best response to a question is really just to ask another question or just give a comment. So if somebody says, they ask a question and it seems like you don't quite understand why they're asking it, rather than answer the question, I would say, I'm not sure I understand why you're asking the question. Could you share with me what your concern is, or what it is why you're asking the question? I better be able to answer it. So sometimes those questions come up when families are resistant or feeling uncomfortable with your line of questioning. And so I think you need to recognize when individuals are showing some resistance or when they're uncomfortable and actually verbalize those concerns. So I might say, these questions can be uncomfortable for some people to answer. I sense that you might be feeling uncomfortable as well. Did I get that right? You don't want to force children or adults, for that matter, to tell you something when they aren't ready. But you want to encourage them to be more comfortable over time, and then perhaps help them identify who else they can speak to when they're ready. So, for example, many years ago, I was evaluating a young child. I think she was probably about 5 or 6, and she'd been sexually assaulted. She had a laceration of her labia that was fairly significant and actually led to a fair amount of bleeding in her underwear. She went to an emergency department at a local hospital and was referred to the children's hospital I was at for evaluation, and I was seeing her in the emergency room. When I asked how it had occurred or how it had happened, she told me that she cut herself when she sat on the bumper of a car and it was pointed and rusty. So I looked at her and I said, well, you do realize you didn't actually rip your pants or your underwear, but you just cut yourself. So that would mean you would have had to sit on the bumper without wearing any clothing, and I'm not sure that I would imagine that wasn't what happened. And I just looked at her and I said, can you at least tell me that you're not ready to talk about it yet? And she looked at me and she said, I can't talk about it yet. So I looked at her and I said, okay, well maybe we can talk about who you can speak to. Who would you feel comfortable talking to about this when you're ready? And she identified her mother. And I said, okay, well, I hope as soon as you leave, you'll become ready to talk about this some more, and you'll go and speak with her because it's important. I actually was just seeing a young boy, he's about 8, and he had been in a very bad accident that actually led to the death of a parent, and he hadn't talked about the accident in over a year. He wouldn't talk to his parent. He didn't talk to a mental health provider that had seen him a couple times. And so initially he was kind of dismissing it as causing any problems. And then I said, well, it sounds like that was a really bad situation. Can you tell me why you don't want to talk about it? And he just said, it's too scary still. I can't talk about it yet. I said, okay, well, I think it would be useful for you to talk to someone else. Let's think about who you might go to speak about that. But that's, I think, I realized there was resistance to talking about it. It wasn't so much that I was trying to confront the resistance, I was just acknowledging it. And I think that's an important first step to being able to talk about these things ultimately. Now, when you meet resistance, whenever possible, it's good to try and explore some of the reason for it. There's a tendency I see with physicians as well as with other non-physicians that they try and explain to people why they should do something based on why they would do it themselves. So in other words, they answer the physician answers the physician's concerns, but really you need to answer the family's concerns. If you're just talking from your own perspective and the other person is just talking from their perspective, then that's actually what we call arguing. But if you really want to move beyond that and deal with the resistance, it's best to understand what their concerns are, because you can really only reassure someone when you know what they're worried about. So I'm going to give you an example from a number of years ago when I was working in a walk-in clinic. This is actually a sick child clinic, I should say, of a primary care center. And it was the clinic was closing late on a Friday afternoon during flu season, and there were actually 2 toddlers who both had been dehydrated and were there and had received rehydration, and the residents that were seeing the children both felt that they could go home. These were unrelated children in 2 different rooms. But the parents were resistant to actually leaving and kept saying, maybe she needs a little bit more hydration, maybe we should go to the emergency department. And the physicians were trying to explain, no, that wasn't necessary, and the urine-specific gravity was low, and trying to explain what urine-specific gravity was. Families were really not interested in learning about specific gravity. They really were worried about their kids. So I went in, and I should tell you, a lot of times people question, well, how can you do this? It takes so much time. I will tell you, this only took a couple minutes and saved an enormous amount of time, because otherwise both of these families would have gone to the ED. So I just met with the first father, and I said, we seem to think that your child's ready to go home, but you have some concerns and are suggesting maybe going to the emergency department. And he said, yeah, I don't think she's ready. And I said, could you tell me what you're concerned about? What is it that you think is not ready about her? And he just said, well, I don't think she'll drink when I get her home. I mean, you've given her fluid by IV, but I'm not going to be able to do that at home. And I said, well, what do you think is going to happen if she doesn't drink? And he said, well, she'll get dehydrated again. And I said, well, what do you think is the worst thing that's going to happen? And he said, well, I'm afraid she might die from dehydration. So I said, well, how long do you think it takes before somebody dies of dehydration if they don't drink? And he said, I have no idea. So I explained that she was, based on her age, her usual bedtime was about an hour later than when we were talking. And I said, does she wake up in the middle of the night to drink? And he goes, no, most of the time not. And I said, so she's not going to become dehydrated by tomorrow morning, because she normally wouldn't drink at all. And we know she's already hydrated, and she's not vomiting, and she doesn't have diarrhea, so she should be fine till tomorrow morning. And we could see her in the clinic tomorrow morning and check her then. but she's not going to get seriously dehydrated if she drinks nothing between now and then. And he just looked at me and said, well, that makes sense. I'll go home and I'll be back tomorrow. I went into the other room and I talked with a mother of a child who also had the same issue. And I said, it seems like you don't think he's ready to go home. What are you concerned about? And she said, well, I'm concerned that he's still not well. And I said, well, what do you think is going to happen when you get home? She said, well, I think he'll be up crying again. And I said, well, what's going to happen if he cries tonight? What concerns you about that? She looked at me and she said, you know, I have been on cocaine and I finally got off of it, and I'm in a drug rehab program, and I've been up for the past couple of nights with him crying, and if he cries one more night, I'm going to start using again, and I don't want that to happen. So with her permission, I called up the rehab program she was in, and they assigned someone to watch him overnight and to also monitor her so that she wouldn't relapse. And then she said, well, if you've done that, I can go home now. So I just mentioned it because 2 kids in 2 different rooms, both with the flu, both with dehydration, both with parents that wanted to go to the ED because they didn't think their child was ready. And what they both needed was very different in terms of reassurance. And I don't think anybody would have known that unless you asked about it. So the next thing I put up here is, you know, realize that you can't take care of all mental health and behavioral health concerns in one session. And I wouldn't even try to do that. There are, of course, some exceptions where there are psychiatric emergencies, such as someone who's suicidal, where you do need to take care of it or at least start the process. So you want to identify any life-threatening or disabling conditions. But other than that, you're not going to be able to intervene on a lot of these chronic issues the first time you see them. And I wouldn't even try to give advice about managing long-term behavioral problems after just 10 minutes of evaluation. It's kind of like prescribing medications for a complicated physical condition before you complete the diagnostic evaluation. So the first step is to evaluate the concern, to offer further evaluation, and to schedule a follow-up. In fact, one of the principles that we learn as consultants is that you don't want to solve a difficult, long-standing problem quickly or easily, even when you think you can. So that when people present because if we go to do consultation to a school, for example, they will often bring a list of the most complicated problems that no one has ever been able to solve and challenge you to solve it. And one of the worst things you could do is to solve it right away. Because if you make it too quickly, if you do it too quickly and make it too easy, it embarrasses them. And so you want to at least make sure that you make it look hard, even if it's kind of obvious what you should do. If you think about it, often what happens is that parents may appear desperate for a solution, but then become insulted if you offer a brief, effective intervention that's seemingly obvious. And then what they will do is they'll find fault with every suggestion. They'll say, yeah, we tried that, but it didn't work. I'm sure that wouldn't work either. Of course, we've already figured that out. Sometimes families really want to complain and to vent, and they aren't always looking for immediate solutions, but they may be looking for empathy and validation. So you want to start by not giving that advice right away. The next point is you want to make sure that you appreciate the limitations of your role. You're there to advise, to support, to counsel, and to treat. But parents often will not take your advice, at least not right away. And some of that relates to what we refer to as stages of change. So families may come in and they may not be even seeing that there's a problem, and then they won't be ready for your suggestion to managing the problem. So I remember seeing one family and their child was very obese as a young child, and the resident was explaining all the things they needed to do related to diet, and was setting up an appointment with a nutritionist and other follow-up appointments. And the family really the mother wasn't really seeming like she would follow through. So I talked with her, and she said, well, you know, if you want me to go, I'll go to a nutritionist. I don't know. And I said, do you have any concerns about his weight? I mean, we're concerned, but how do you feel about it? She said, well, quite honestly, I was that weight when I was his age, and I outgrew it. So, no, I'm not really concerned. So then I just went over and said, well, maybe what we can do today is we can share with you some of our concerns. You're saying you're not feeding him excessive amounts or more than usual. So why don't you do this? I want you just to keep a list of everything that he's eaten in the next week. And then you can come back and we'll just share that information and discuss it. And maybe that'll give you maybe we'll have a better sense then of actually what your son is eating during that week. And we're not going to give you the appointment for the nutritionist or all these other appointments, because at this point, let's just work on making sure that you feel comfortable that you also have the concerns. And then at that point, she kind of looked at me and said, okay, fine, I'll go to the nutritionist if you want. And I said, well, it's not that I want it. It was just a recommendation, but let's hold on it until you're more convinced. And then over time during that visit, she finally looked at me and said, I'm not leaving this office unless I have an appointment for a nutritionist. This is important. But I think if I had just given the nutritionist appointment at the beginning before she really felt it was something that she had concerns about, it would be very unlikely she would have shown up for that appointment. The next point I have here is that you want to make sure that you maintain boundaries. So my recommendation is that you limit the sharing of personal information. Sometimes families will ask personal information even when they're not actively seeking it. Remember one father came in, he was bringing his son for a scheduled visit for another condition, and he mentioned to me and he said, Doc, my older daughter just ran away from home and she hasn't come home yet. And he looked at me and he said, do you have any kids? Have they ever run away from home? Well, there really is no reason for me to answer that question, because whether or not my child or children have ever run away from home isn't really relevant in this conversation. If I say no, then it's kind of like saying, well, my kids would never run away from home. I know how to parent them. And if I said yes, then why would I be giving advice on how to deal with the issue if my own children run away from home? So I don't really know that there's any answer to that that would have been helpful to the father. And to be quite honest, I think it was just a way of phrasing his concerns. So I didn't answer the question, and it didn't matter. All I said was, oh, that must be very difficult. Tell me a little bit more about what happened, and do you know where she is, and are you worried about her safety? And that's what he really wanted to talk about. He didn't want to talk about my personal experiences. I also think you don't want to give advice on parenting based on how you were raised or how you raised your children. You certainly can draw on your experience, but you want to personalize the advice. You want to base it on science and best practices, but also then tailor it to the unique situation and context of the family, including their culture. You don't really want to tell families how to do things based on what you do or based on what was done to you when you were a child, but instead on what works for them. So actually, I don't usually say, if this were my child, I would do X, because it isn't my child, and what the family should do is what works best for them. You certainly can share your opinions and obviously definitely share your advice based on your knowledge and experience, but it's really based on helping them figure out what works best for them. The last slide that I have just summarizes some core communication skills for doctor-patient interactions that were described by Bill Coleman. I'm going to go over these very quickly and then just open to questions. So the first is active listening. And in active listening, you have certain behaviors that demonstrate to individuals that you're listening carefully and processing what they're saying. That's through body language, such as head nodding, eye contact, responsive facial expressions, or brief verbalizations. You know, for example, when you're doing a webinar, you can't tell if anyone's even listening, and it actually makes it very difficult to speak and continue the conversation. And if you've ever been on a phone call and people just say, "Are you still there?" That's because you haven't said "aha" or used one of these other techniques in addition to active listening. Reflection is repeating back key words or phrases, generally in the patient's own words, for emphasis or clarification. So, a parent is talking with you and says, "So when your child does that, you're very frustrated." So you're just reflecting back and they go, "Yes, it really frustrates me." It's related to active listening. You're just kind of saying, "I got it. I'm here with you. I'm just reflecting back." And sometimes what will happen is they'll say, well, no, that's not the issue. You didn't get that right. And you go, oh, well, then explain to me what you were trying to, what I didn't get right. Help me understand it better. Elaboration is describing or amplifying statements or questions, like tell me more. Can you give me a little bit more information about what happened there so I can understand it better? And silence is actually very useful for encouraging elaboration. The next one is clarification, which is just asking for clarification, encouraging families to request clarification. This is just to make sure, again, that you've got effective communication and comprehension. So let me make sure I understand. You were saying that this happened and that caused X to occur. Did I get that right? So you're asking a question to clarify a point. Empathy is the ability to understand with emotion. You want to understand and appreciate the emotion, but you don't have to share the emotion. So you can actually teach people to appear empathic. It's not that you really have to feel in a particular way. You just have to make sure that you understand and appreciate the emotion that the person has. The next one is confrontation, and here it would be more gentle confrontation. This might be asking a direct question or making a statement to gain a more truthful answer or interpret or resolve what you perceive to be a conflict. So you might say, for example, you seem to be upset about your parents' divorce, and you're telling me you have trouble sleeping and eating since they told you they're divorcing. But you also tell me you don't seem to care and it's just between them. So do you think the fact that they're talking about divorce really doesn't matter to you? So again, it's gentle confrontation. It's kind of saying, well, you're telling me one thing and you're telling me the other thing. So which one do you really think it is? The next one is interpretation. You're helping people explain a phenomenon. So you may want to offer interpretations instead of directives. So, it sounds like you're very angry with your father would be better than you shouldn't talk to your father that way. It's disrespectful. Or that's not a very nice thing to say about your dad. So what you're doing is you're just kind of offering interpretations. So you may say, it sounds like your father gets very upset when you express your anger that way. Can you think of another way you might communicate that you're upset that wouldn't make him so upset as well? You can also use reframing, which is a specific type of interpretation. So, for example, when parents come in and they say, whenever, mother says, whenever I set a limit on my child, he gets very upset, but, a babysitter can do it and he doesn't get as upset. And so part of what you can explain is, well, your child might actually be more sensitive to limits that you place because he cares more about you and thinks it's really very important to please you. And so that's a kind of a reframing so that they see that the behavior isn't necessarily because the child doesn't respect or like them, but in fact it may actually be because the child does have a lot of respect and does care. Then I have silence as another technique, which I've already mentioned. Silence allows patients to reflect, organize their thoughts and feelings. It encourages them to elaborate and sometimes to just regain composure if they've been upset. Tracking is subtly adapting your language, your body language, your style, and your pace of interview to that of the family. I think I mentioned this before in another presentation that people pick up on your affective tone. They pick up on your tracking, sometimes more than actually what you're saying. So I've given very bad news in emergency situations, and people just pick up on my being calm and the pace that I'm speaking at. And that can actually be very reassuring to people, and they'll often calm down as a result. But the issue is if they're extremely agitated and you're way too calm, sometimes they'll think you're not listening to them or understanding that they're concerned, and you might need to pick up your pace a little or put a little more affect into what you're saying to come a little closer to where they're at. And then summarizing is just paraphrasing, condensing, or recapitulating. It really helps establish some organization and closure, and it sets the family up for the diagnosis, which is really the ultimate summarizing technique. So I'm going to stop there. I just thought it might be useful to go over some of these core communication skills, and then I'll open it up now to questions.